The skin of an elderly person takes on this tone days before death. Hello, I am Doctor, a geriatrician, and welcome back to the Integral Health Channel. Today, we are tackling a topic that often whispers in the quiet corners of hospitals and homes, bringing with it tremendous fear and confusion, the physical signs that signal the end-of-life process. Specifically, we are going to look closely at one of the most visible yet frequently misunderstood changes, the particular tone and appearance the skin of an elderly person often takes on in the final days of their life. This is a difficult conversation, I know. Death is the final taboo, and when it approaches a loved one, the natural impulse is fear, panic, and a desperate search for answers. But as a doctor who has walked alongside countless families through this final transition, I can tell you that knowledge does not hasten the end. Rather, it allows for peace and dignity. My goal today is not to frighten you, but to equip you with the clarity you need to shift from frantic caregiving to compassionate presence. To illustrate just how critical this understanding is, let me share a story. A few years ago, I was consulting on a patient named Eleanor. She was 92, and her daughter Sarah was her devoted caregiver. Eleanor had been declining steadily for several months, and the decision had been made for comfort care at home. Sarah was doing everything right, managing pain, ensuring hydration, speaking softly to her mother, but she was constantly on high alert, terrified that she would miss the crucial moment when something went wrong. One Tuesday afternoon, Sarah called me, her voice ragged and tight. She said, "Doctor, I don't know what's happening. Mom's hands are cold and they look purple, not bruised, but like stained glass, and her knees look mottled. Is she cold? Did I miss something? Is this the moment I need to rush her to the hospital?" The panic in Sarah's voice was palpable. In her mind, the change in her mother's skin tone, this dusky, bluish, marbled appearance, was an acute medical emergency, a sign that her mother was suddenly freezing or suffering internal trauma. I listened carefully, and then I delivered the direct, difficult, yet necessary truth. I told Sarah, what you are seeing is not a sign of cold, and it's not an acute emergency that requires rushing to the ER. What you're seeing is a natural, expected part of the dying process. It is what we call mottling. It means Eleanor's body is conserving resources. The blood circulation is pooling in her core organs, protecting the heart and brain, and withdrawing from the extremities, her hands, her feet, her legs. I explained that the marbling pattern, that purplish lace-like discoloration, was a clear indicator that her body's peripheral circulation was shutting down. It's an irreversible physiological sign that the body is preparing for its final days, sometimes hours. The relief Sarah felt upon hearing that this frightening change was expected, not an accident caused by her lack of care, was immense. She wasn't relieved that her mother was dying, of course, but she was relieved that she didn't have to panic, and she didn't have to subject her mother to stressful interventions. She could simply be there, holding Eleanor's mottled hand, knowing this was part of the natural conclusion. This is why we must talk about this today. It is perfectly natural to fear these changes. When a loved one's skin begins to look different, cooler, paler, sometimes taking on that specific dusky, marbled tone, your heart leaps into your throat. You immediately think of resuscitation, of oxygen masks, of warming blankets. You fear that you have failed them by not recognizing a severe, treatable problem sooner. I want to validate that fear right now. You are doing a tremendous job. The confusion you feel is normal, but when it comes to the end-of-life journey, the rules of care change. We stop fighting the physiological reality and focus entirely on comfort and dignity. In this deep dive, I'm going to strip away the medical jargon. We will discuss exactly why this dusky, mottled appearance occurs, where on the body you will typically see it start, usually the feet and lower legs before moving up the arms and chest, and what this specific change tells us about the timing of the transition. Most importantly, I will provide you with clear, actionable steps for managing comfort and maintaining dignity when you observe this critical visual sign. You will leave this session prepared, compassionate, and focused on providing loving presence, not frantic intervention. Let's begin by defining exactly what this skin change looks like so you know precisely what to look for. We must be precise. The critical visual signal we are discussing, the change in skin tone that often precedes death by hours or a few days, is known medically as mottling, or in severe cases, cyanosis. When a person is approaching the end of life, the body begins a critical process of prioritizing. Think of it as an internal triage system that focuses exclusively on keeping the essential engine running, the heart, the lungs, and the brain. Everything else is gradually shut down. The skin, being the largest organ and furthest from the core, is the first to show these changes. What exactly happens? It comes down to blood flow and pressure. As the body's metabolic needs decrease and the heart grows weaker, blood pressure naturally drops. The body's circulatory system starts struggling to push blood out to the farthest reaches, the fingers, the toes, the hands, and the feet. When oxygen-rich blood, which is normally bright red, cannot reach the extremities efficiently, the peripheral tissues rely on the remaining slow-moving blood. This sluggish blood has already dropped off most of its oxygen, and it begins to pool. This pooling of deoxygenated blood under the skin is what creates the visual sign we call mottling. Mottling appears as a purple, bluish, or reddish, lacy, marbled pattern. Imagine a marble countertop with veins running through it. That's often what it looks like, especially across the knees, feet, and lower legs. The skin will also often feel cold or clammy to the touch in these areas. This is a direct and unmistakable sign of peripheral circulatory failure. It is not just poor circulation, it is the body making the choice to conserve resources for the core. It is absolutely vital, particularly for caregivers, to understand the difference between these terminal changes and the normal benign skin changes that happen simply due to advanced age. If you miss this distinction, you may cause undue panic or intervene aggressively when comfort is the only appropriate response. Normal aging causes the skin to become thinner, drier, and more fragile. We see conditions like senile purpura, which are those easily recognizable bruises or purple patches that occur from minor bumps, because the blood vessels beneath the thin skin are delicate. These are common, they are local, and they are usually painless, requiring simple protection. They do not signal systemic failure. In contrast, terminal mottling is a systemic process. It is symmetrical, it happens on both legs or both arms, and it progresses rapidly. It moves up the limbs toward the trunk. If you observe mottling that has moved past the knees or elbows, it is a very strong indicator that the patient has only a short time left, often measured in hours. A key indicator to look for is non-blanching discoloration. If you gently press on an area of normal skin, it will temporarily turn pale and then return to its color. When the skin is mottled due to circulatory failure, pressing on it often does not result in a return to normal color because the blood flow is essentially stalled. Now, observing this sign, this visual confirmation that the body is shutting down, must trigger not a panic response, but a confirmation response regarding the patient's existing plans. This is where the concept of advanced directives becomes incredibly relevant. Advanced directives, or living wills, are not just legal documents. They are a direct communication of the patient's wishes when they can no longer speak for themselves. Have they expressed a desire for a peaceful death at home? Have they established a do not resuscitate or DNR order? When you see the skin changes, the coldness, and the mottling, your immediate focus should shift entirely to comfort care. It is time to review those directives. The physical sign is telling you the time for aggressive treatments, hospital transfers, or complex interventions has passed. Trying to reverse this circulatory failure is often painful, unnecessary, and goes against the natural process the body has already initiated. If the patient has indicated, "When I am actively dying, I only want comfort," observing the mottling is your signal to follow that wish strictly. You increase pain medication if needed, adjust the environment for peace, and focus on loving presence. You are not fighting the condition. You are supporting the person. If, however, advanced directives were never put into place, seeing this level of physical decline presents a difficult but necessary moment of clarity. If the patient is still semi-conscious or able to communicate even minimally, the family must immediately confer with the medical team to establish realistic goals of care, which, at this stage, should still default heavily to comfort. If the patient is unresponsive, the family must rely on prior expressed values and the medical team's guidance to ensure interventions are gentle and respectful of the body's final processes. The cause of this end-stage circulatory compromise is always rooted in the primary disease process, be it advanced heart failure, end-stage kidney disease, severe dementia, or cancer. Regardless of the originating illness, the final common pathway involves the failing heart's inability to maintain pressure and volume. We are not dealing with a simple infection that can be treated with antibiotics. We are dealing with global, irreversible organ decline. Understanding the physiology, that the lacy pattern is a map of where the blood has stopped flowing effectively, removes the fear of the unknown. It replaces it with certainty. You know what you're seeing, and you know what it means. It means the focus moves from curing to caring. Remember, the skin is just the outward manifestation of deep, core changes. The mottling tells us the heart is struggling immensely. The kidneys have likely ceased functioning effectively, and the body's reserves are exhausted. Your primary duty when observing this critical tone change is to provide warmth, using blankets, never heating pads as the skin is too fragile, and to ensure the patient is pain-free. Do not panic about the color. Understand its message, which is an invitation to deepen your connection in the final moments. In our next segment, we will discuss the specific steps for providing this comfort care, focusing on management of pain and breathing in light of the severe circulatory compromise. We established that the change in the skin tone, that mottling, that purplish lace-like pattern often starting in the extremities, is not a moment for panic, but a clear signpost indicating that systemic circulation is diminishing. This is the body preparing for its final rest. Now, we must shift our focus entirely to providing the highest level of comprehensive comfort. This segment is dedicated to the practical, detailed steps every caregiver and family member needs to implement immediately upon seeing the severe circulatory compromise. Your first step, and this is non-negotiable, is to activate your established support system. If you have a hospice or a dedicated palliative care team, call them. This is what they are trained for. Do not attempt to manage these final, crucial hours alone. They will provide the expertise and the prescribed comfort medications necessary to manage what we call the triad of distress in end-of-life care: pain, air hunger, and restlessness. Let us focus first on the management of physical comfort, starting with pain. Step 1. Proactive pain management. At this stage, your loved one may be unable to verbally communicate their pain. We must rely on nonverbal cues. Look for signs of discomfort: grimacing, furrowing the brow, moaning, clenching of hands, or simply an inability to rest peacefully. If you see mottling, you must assume discomfort is present, even if subtle. You must be proactive, not reactive, with pain medication. If the hospice team has provided liquid morphine or other breakthrough pain medication, often called PRN or as needed medication, use it according to the prescribed frequency, even if you are unsure if they are in severe pain. I know the common fear associated with opioids like morphine. I hear it every day. Doctor, am I shortening their life? Am I hastening the end? Let me be absolutely direct. In the context of end-of-life care, managing pain with appropriate dosages of medication does not hasten death. It provides dignity and comfort. The body's systems are shutting down due to the underlying terminal illness, not the carefully calibrated dose of medication given for comfort. Your goal is peace, and we achieve peace by ensuring pain is fully controlled. Do not let fear of the medication prevent you from providing necessary relief. Step 2. Addressing respiratory distress, air hunger. The skin discoloration is intrinsically linked to failing circulation and poor oxygen delivery. Even if the lungs are functionally fine, the sensation of air hunger, the feeling of needing to breathe, can be profoundly distressing. There are powerful non-pharmacological interventions here. The easiest, most effective tool is a small electric fan. Directing a gentle stream of cool air across the patient's face, even if they are not overtly hot, provides a strong sensory input that alleviates the feeling of suffocation. This simple step can dramatically reduce anxiety and the subjective feeling of breathlessness. Next, physical positioning is critical. Elevate the head of the bed to a 30 or 45 degree angle. This uses gravity to help reduce the pressure on the diaphragm and makes breathing slightly easier. Use pillows to prop the person comfortably on their side, if tolerated, or ensure they are properly aligned on their back. If non-pharmacological methods are insufficient, this is where prescribed anti-anxiety medications, like lorazepam or low-dose opioids, which reduce the brain's perception of air hunger, become essential tools. These medications quiet the distress center in the brain, allowing for calmer, slower breathing. A note on the death rattle. You may hear gurgling or wet sounds in the throat. This is the accumulation of secretions, because the person no longer has the energy or the reflex to cough or swallow effectively. This sound is almost always more upsetting to the listener than to the person experiencing it, as they are often deeply unconscious or unresponsive when it occurs. To help mitigate this, gently reposition the patient to their side. Your palliative team may also recommend anticholinergic medications, such as scopolamine patches or atropine drops, to help dry up these secretions. Step 3. Managing temperature and skin integrity. As the mottled pattern progresses, the extremities will become cool to the touch. This is a normal physiological process as the body redirects blood flow to the vital organs, the core. Crucial instruction regarding temperature. Do not use heating pads or electric blankets. The severely compromised circulation means they will not feel the heat adequately, and you risk causing severe, debilitating burns because the tissues are extremely fragile and cannot dissipate the heat. Instead, use light, soft flannel blankets placed over the body, focusing on the core and perhaps slightly covering the feet and hands. Gentle, comforting touch remains essential. You may use a light, unscented moisturizer on the skin, using very gentle strokes. Avoid any deep pressure or vigorous rubbing that could damage the delicate skin. Step 4. Adaptation of medications. The review. When mottling begins, we must immediately review the patient's entire medication list with the palliative or hospice physician. Any medication that is purely preventative or intended for long-term benefit must be stopped. This includes vitamins, supplements, cholesterol-lowering drugs, statins, blood thinners, and many routine blood pressure medications. These medications are now a burden on the system and often require swallowing efforts that cause distress. The focus narrows to the essential comfort medications, pain relief, anxiety control, and secretion management. Everything else is discontinued to ease the burden on the patient. Step 5. Nutrition and hydration, the hardest conversation. This is perhaps the most difficult instruction for families to accept, often generating significant guilt. When circulation fails, the entire metabolic system is shutting down. The body is no longer capable of processing food or liquids effectively. Attempting to force food or large amounts of fluids, either orally or via IV, is counterproductive and often harmful at this stage. It can lead to nausea, vomiting, aspiration, choking, fluid accumulation in the lungs, worsening the death rattle, and edema, swelling. I need you to internalize this important clinical fact. At this very late stage, dehydration is not painful. In fact, a naturally occurring mild state of dehydration often releases endogenous opiates, which are the body's natural pain and anxiety relievers. Your goal shifts from providing nutrition to providing oral comfort. This means focusing on keeping the mouth moist. Use moist sponges, sometimes called touthettes, dipped in water, lip balm for cracked lips, or perhaps offer tiny ice chips or very small sips of water, only if the patient shows clear interest or can swallow easily. If they resist or struggle, stop immediately. Let go of the guilt surrounding feeding. You're not starving them. You are respecting the natural process of the body closing down. Step 6. The environmental and emotional protocol. As we approach the end, the sensory inputs you provide become paramount. Hearing is the last sense to go. This is a critical point. Always assume your loved one can hear you, even if they appear unconscious or unresponsive. Maintain a calm, quiet environment. Soft, indirect lighting is best. Limit the number of people in the room to 2 or 3 at any given time to keep the atmosphere peaceful. Speak slowly, clearly, and naturally. Hold their hand. Share memories. Read familiar passages, poems, or scripture. This is your final, profound opportunity for connection. Tell them how much they are loved, how proud you are, and reassure them that you will be okay. And perhaps the most crucial piece of advice for the caregiver, give them permission to go. Sometimes a person waits until their loved ones are explicitly ready and have given them permission to finally rest. Seeing the mottled skin and cool extremities is a definitive signal that the end is measured in hours, or perhaps a very few days. Your role now shifts from active intervention to peaceful presence. Embrace the silence. Be present with your love. Trust your hospice or palliative team completely, and trust that you have done everything right by prioritizing their comfort and their dignity in these final, sacred moments. We have covered the critical physical shifts, the changes in skin tone, the altered breathing patterns, the withdrawal, signs that, while deeply unsettling for the caregiver, are the guides for our care approach in these final days. If you are seeing these signs, you must remember the most crucial takeaway from our entire discussion. We are now managing symptoms, not seeking cures. Your loved one's body is naturally winding down, and this process is managed by their internal biological clock. Aggressively pushing fluids, forcing food, or continuing complex medications that do not directly address pain, anxiety, or comfort is often counterproductive. In fact, aggressive intervention can sometimes increase their distress and prolong a stage they are naturally ready to exit. We, as devoted caregivers, often feel a fierce, almost instinctual compulsion to do something. We see the slowing down, and we interpret it as a failure on our part to nourish them. But sometimes, the greatest, most profound act of love is allowing things to unfold naturally, guided completely by the meticulous comfort measures prescribed by your hospice or palliative care team. Let me be direct. Stopping unnecessary medical interventions in this phase is not giving up. This is elevating dignity. This is honoring the natural conclusion of life by prioritizing peace over procedure. Now, let us turn our attention to what you, the present caregiver, can still offer. It is immense. I want to debunk a very common fear right now. Many families worry that because the patient is unresponsive, they can no longer hear them or feel their presence. Remember this fact, which is supported by extensive medical studies. Hearing is often the very last sense to go. They can hear you. Speak to them. Tell them your favorite stories. Recite poetry or sing a song they loved. Remind them how much they are cherished, how proud you are of the life they lived. Even if they cannot respond or acknowledge you, the sound of your voice, familiar, loving, and steady, is profoundly soothing to the conscious or subconscious mind. Do not shy away from touch. Hold their hand. A gentle stroke on the forehead, the simple resting of your hand on their shoulder, communicates everything the heart needs to say without needing a single word. This presence, this physical connection, is the most powerful comfort drug we have in these final moments. I also want to address the heavy weight of caregiver guilt. Many of you struggle deeply in these moments, asking, did I do enough? Should I have acted sooner? Did I miss a sign? I want to tell you directly, as a geriatrician who has sat bedside countless times, you have done enough. You have done your absolute best with the information and resources you had. Guilt is a natural response, born of deep love, but you must release the need for perfection. The only requirement now is compassion, for them and for yourself. Give yourself permission to mourn while you are present. The goal now is not longevity, it is peace. We are honoring the life that was lived by ensuring the departure is as tranquil and pain-free as medically possible. When we prioritize comfort and presence over procedures and panic, we are performing the final, most sacred act of caregiving. This transition, while undeniably heartbreaking, can also be profoundly beautiful, a testament to a bond that transcends physical presence. This journey is often walked in isolation, but it does not have to be. If this conversation resonated with you, if these honest insights brought even a small measure of clarity or comfort during a difficult time, please consider sharing this video with others who might desperately need this information. Press the like button, subscribe to the Saud Integral channel for more direct, reliable advice on aging, health, and end-of-life care, and leave a comment below sharing your strength or your questions with our community. I am committed to supporting you through these complex, tender times. Thank you for inviting me into your home and into your heart today. Until the next conversation, prioritize compassion, prioritize clarity, and prioritize your peace.